So I will talk in this section about one lung ventilation. Routinely, during mechanical ventilation, both the lungs are inflated and deflated together. But when we mechanically separate one lung from another, we can practice one lung ventilation. And this is a standard procedure done during thoracic surgery to improve the visualization of the surgical field. In this section, I will talk about the indication of one lung ventilation. I will talk about where it is not feasible to do one lung ventilation, what is the changes in the lung physiology during ventilation in an awake patient and anesthetized patient, and why does ventilation perfusion mismatch increases in one lung ventilation, and what are the ways to combat it. We'll also talk about a very important physiological response seen in our body, that is hypoxic pulmonary vasoconstriction, which protects us against this ventilation perfusion mismatch to a great extent. So we'll talk the hypoxic pulmonary vasoconstriction as well. And I will also talk what are the practices which we do to minimize the complications during one lung ventilation. How do we practice the mechanical ventilation during one lung ventilation? If hypoxemia happens, how do we combat the hypoxemia? Everything we will discuss. So let us start with the indication. Now, indication of one lung ventilation can be divided into two broad divisions. One division would encompass all those indications for which one lung ventilation is practiced for giving us a better surgical exposure during surgeries like esophageal surgery, mediastinal surgery, or pulmonary surgery, pneumonectomy, lobectomy, etc. And the other group would encompass all those reasons why we practice one lung ventilation when we want to separate one lung from another because of pathology of one lung which we don't want the other lung to catch up, right? So these are the two broad reasons for practicing one lung ventilation. So what I said, that one lung ventilation, this is practice number one to improve the exposure of the surgical field. So it is used to improve exposure of surgical field, right? So in what surgery we want one lung ventilation, we want one lung to be collapsed, which is in vicinity of the surgical field to give us a better surgical exposure. So the indications for those kind of surgeries are the pulmonary resections like pneumonectomy, lobectomy, or wedge resection that we practice, Watt's procedure, that is video assisted thoracic surgeries, mediastinal surgeries, esophageal surgeries, thoracic aneurysm surgery, then your thoracic spine surgery when we go for the anterior approach, then minimally invasive cardiac valve surgery. In all these surgery, a non-ventilated collapsed lung is required in the vicinity of the surgical field to improve the access to the thoracic cavity. So for a better access to the thoracic cavity, we need the one lung to be collapsed, right? So for a better surgical visualization, one lung ventilation is practiced. And the other indication for practicing one lung ventilation is when we want to anatomically separate one lung from the pathology of the other lung. So to anatomically isolate one lung from pathology of other lung, right? So what could be the reason for, what reasons would come under this division? Hemorrhage happening in one lung, purulent secretion in the one lung, when we have to do a whole lung lavage in pulmonary alveolar proteinosis, etc. Then when we want to differentially ventilate both the lungs, one side of the airway has a bronchopleural fistula and we do not want to give more pressure during ventilation of that lung, so we can practice one lung ventilation. So for decrease pressure or airflow to the side of the pathology, as in bronchopleural fistula or unilateral cyst or bully. Apart from this, there is a concept which is coming, differential lung ventilation, in which two ventilators is being used to ventilate both the lung, because both the lungs during number of lung pathologies, their physiological condition is different, and we need to practice ventilation differently in those patients. So still this is in experimental phase, the differential lung ventilation, but concept of differential lung ventilation is also coming. So these are the indication of one lung ventilation. One group for the better surgical exposure, and the other group to avoid cross contamination of one lung to other during some lung pathology. Okay, so what are the conditions where we cannot, the one lung ventilation is not feasible? Now, patient is not tolerating one lung ventilation. When you are doing one lung ventilation, one whole lung is not getting ventilated. So the shunt fraction is increasing. We'll talk about how much is the shunt fraction, how can we minimize the shunt fraction. But there are patients who cannot tolerate even a little increase in the shunt fraction above the already increase in shunt fraction because of their lung pathology. So they are not tolerating one lung ventilation. When we are putting them on one lung ventilation, severe hypoxemia is happening. We cannot practice. It is not feasible in these patients. Then if we cannot separate one lung from another, then again one lung ventilation is not possible. So one lung ventilation is not feasible, if number one, patient not tolerating it, not tolerating the hypoxemia, not tolerating one lung ventilation, severe hypoxemia is happening. Second, it is not possible to separate both the lung. When it is not possible to separate both the lungs, right? So there are conditions where we cannot separate one lung from another. There is a tumor or the mass in the bronchus, we cannot put a double lumen tube, or we cannot put a bronchial blocker. It's not feasible to separate both the lung. So in those conditions also one lung ventilation cannot be practiced. So once we have discussed indication and where we cannot practice one lung ventilation, there is no absolute contraindication of one lung ventilation, right? There is nothing like absolute contraindication. Okay, we need to understand the physiological changes and the shunt fraction which would increase during one lung ventilation. We need to understand normal lung physiology in an awake patient, awake ventilation, what changes happens during awake ventilation in the lung when the person is awake, and second, when the person is anesthetized. What does anesthesia do to the lung ventilation? So we need to first understand this, and then I will talk about that during anesthesia, what further problem will happen during one lung ventilation. So first, let us talk about lung physiology, right, during in an awake patient. So when a patient is awake, so this awake patient could be in any posture. Patient could be supine, patient could be prone, patient could be in lateral decubitus position. Let us divide the lung into two parts, dependent part, non-dependent part. So I have divided the lung of an awake patient into dependent, right, and non-dependent part, okay. So what would happen to the perfusion in dependent part of the lung? Perfusion is gravity dependent. So always the dependent part of the lung would get more perfusion. So more blood supply, dependent part of the lung would get more blood supply. So more blood supply means better perfusion. So dependent part of the lung is getting better perfusion. What about ventilation? Now dependent part of the lung is getting better ventilated also. There is something called lung compliance curve. What is lung compliance? Change in the volume with the change in the pressure when the pressure is applied. With change volume, with change pressure. That is delta V by delta P. So this is what is your lung compliance, change in the volume on the pressure applied. Now there is a lung compliance curve. So let us talk about that where does dependent part of the lung lies on the lung compliance curve. So if you see this image of lung in awake patient, as I have divided the lung into two parts, the dependent and the non-dependent part. Now dependent part of the lung, where does it lie in the lung compliance curve? This is the lung compliance curve, right? Change in the volume, change in the pressure. So this is a sigmoid shaped curve, and the middle part is the best area where the lung can, where the portion of the, if the portion of the lung would lie, it would be better ventilated. And dependent lung falls in this middle part of the lung compliance curve. What do I mean by this? What happens on the dependent lung? Dependent lung is, because it is dependent, it is how it is better ventilated. Dependent lung is more compressed, and because of the compression, right, uh, once the air starts filling it, the lower segment of the lung would be atelectatic because of the compression. The air starts filling it. Then once the lower part of the lower segment, the atelectatic segment starts opening, then at lesser pressure, more the volume will increase. When initial hitch in increasing the volume has been overcome, that is atelectatic segment has been opened, then with a little increase in pressure, more volume will fill the lung. Let us understand this concept, how we inflate a balloon. Think your lung as a balloon, okay? So when we start blowing a balloon, initially we need more pressure to increase a little volume. But once that little volume has been achieved in the balloon, with a little increase in the pressure, more volume will increase, right? There is a scope of more volume to increase. The segments are compressed. So, right, the basal segment is atelectatic. Once the basal segment opens, with a little pressure, more and more volume will expand the entire lung. So, ventilation would be also better. But non-dependent lung, that they are not compressed, so they already have a, they are non-compressed, so they already have air filled in it. So to further increase its volume, more pressure would be required. So if you see the non-dependent lung, where does it lie on the compliance curve? It lies on the upper part of the compliance curve, where we need to increase more of the pressure for a little increase in volume, because already the volume is high in the non-dependent part of the lung. Okay, so ventilation is also better in the dependent part of the lung. So dependent part of the lung gets more blood supply, and it also gets more ventilation, right? Why this more ventilation? Because they are slightly compressed. So at present the ventilation is, I mean, they are compressed, so there is not adequate air in it. There are atelectatic segment. Once the atelectatic segment opens, little pressure would increase more of the volume. So ventilation is ventilation is slightly more, as they are compressed. So compressed segment would definitely will have a greater compliance. So they are compressed, so they have greater compliance. They can increase their volume more. They have a better compliance, right? So once the atelectatic segment has opened, little pressure would increase more of the volume. Non-dependent lung is getting less blood supply, less blood supply, okay, and less ventilation, because they are already big. So to change the volume more, we would need more pressure. So less ventilation, less blood supply. So this maintains something called ventilation perfusion matching. The segments which are better ventilated should be better perfused, and this is happening in the dependent part of the lung. The segment which is less ventilated should be less perfused, and this is happening in the non-dependent part. So the ventilation perfusion match is maintained. So in awake patient, right, VQ is well matched. VQ is well matched. Okay, what we need. So shunt fraction is very minimal. Shunt is hardly 1 to 2%. So hardly there is a shunt fraction, only 1 to 2%. Right, everyone? Okay. So what happens when we anesthetize someone during anesthesia? So what happens during anesthesia? So when we give anesthesia to someone, we paralyze the person, right? Paralysis would paralyze the diaphragm and the intercostal muscle. So both the paralysis of diaphragm and the intercostal muscle would decrease the functional residual capacity. So FRC would decrease. Other thing which will happen during anesthesia, the mediastinal structure, they will become relaxed. So fall of the mediastinal structure would be seen in the under anesthesia. So two major problem. Number one, FRC decreases as diaphragm and chest wall muscle is paralyzed. Chest wall muscle is paralyzed, right? And the second thing happens, mediastinal weight becomes unsupported. Mediastinal mediastinal weight becomes unsupported, right? So because of both these changes, what happens in the lungs, dependent and non-dependent part. So under anesthesia, again if I divide the lung into dependent and non-dependent part. So dependent part of the lung, it changes its position on the lung compliance curve from the, let's say, from the this is the dependent part. In awake patient, the dependent part is on the middle portion of the lung compliance curve, a better place. So under anesthesia, because of the change in the lung physiology, the dependent part shifts lower. It shifts lower, right? It goes into that non-compliant part of the lung compliance curve where more pressure is required for increasing the volume, right? The dependent part. And more compressed, and so it is very difficult to increase the volume in them. More and more pressure is required. The compliance is reduced. And the non-dependent part in anesthetized patient shifts to the favorable position, shifts to that portion of the lung compliance curve where they are better ventilated. So in awake patient, the non-dependent part was on the upper part, right, where there was less ventilation happening. And in anesthetized patient, the non-dependent part goes into the steeper part of the lung compliance curve where more ventilation it is receiving. So non-dependent is receiving more ventilation, right? Here the dependent is receiving more ventilation, and dependent part of the lung in anesthetized patient is receiving less ventilation, right? And non-dependent in awake patient is receiving less ventilation. So scenario changes. But ventilation scenario changes. Perfusion scenario is still the same because perfusion is gravity dependent. So whether it is awake or anesthetized patient, the perfusion of the dependent lung would be more. So more perfusion. Here also there would be more perfusion. So here less ventilation, more perfusion in dependent part of the anesthetized patient, lung of the anesthetized patient. So this would increase the ventilation perfusion mismatch. So under anesthesia, because of the change in the lung physiology, because of decrease in the FRC and because of the mediastinum compressing more on the lungs, mediastinal weight becomes unsupported. The lung the non-dependent part goes into the better part of the lung compliance curve, and dependent part, which should get better ventilation, goes into the lower part of the lung compliance curve, right? So what I am trying to explain you, that when the patient is anesthetized, right, the dependent part of the lung moves lower in lung compliance curve, and the non-dependent part of the lung reaches the steeper part of lung compliance curve, which is the better part, right, but the perfusion is same. So ventilation perfusion mismatches more. So what happens? The top lung, what happens? Ventilation perfusion mismatch. So first I should write ventilation perfusion mismatch, right? Mismatch happens under anesthesia. Now, what would thoracic surgery contribute in it? Now, the chest wall is open. So, chest wall is open. The resistance caused by the chest wall on the top lung, on the non-dependent lung has gone. So, non-dependent lung would again get a better ventilation, right? So, if let's say chest wall is open, chest wall open, even better perfusion, even better, sorry, ventilation of non-dependent lung, of non-dependent lung. So anyhow, under anesthesia and during thoracic surgery, the top lung is getting more ventilation. The non-dependent lung is getting more ventilation, right? Okay, it is getting more ventilation, okay, and it is getting less perfusion. So this would increase VQ mismatch, VQ mismatch. So this is one way of increasing the reason for increasing the VQ mismatch. Now, if this top lung is, let's say, collapsed, right? If it is collapsed, then entire 50% of the lung is now not getting ventilation. So more VQ mismatch. So if top lung collapse, more VQ mismatch, more VQ mismatch. So if we just see mathematics according to the collapse of one lung and ventilation of only the other lung, then this simple mathematics tell us that 50% of the shunt fraction should become 50%, right? So non-dependent, dependent lung. If the non-dependent lung is collapsed, the one lung is not getting any ventilation, so shunt fraction should be 50%, right? According to mathematics. But everything is not mathematics, because there are a lot of physiological changes which happen and which fight against this shunt fraction. So in reality, 50% shunt fraction is not seen as it should have been seen by simple mathematics. It is only 10 to 20% shunt fraction. So how is the lung protecting against this increased shunting of the blood? Now, there are three reasons during thoracic surgery which protects from this increased shunt fraction. So we'll talk about those three.